So yes, we are talking about urinary tract infections, and when you talk about urinary tract infections, basically you are looking at different things. Now, urinary tract infection technically can be again divided as per, when you talk about using antibiotic, it is whether, first of all, are you using it in the for the lower tract or the higher tract. Now, when you talk about any antibiotic, the three things is selection of antibiotic, the dosage of antibiotic, and finally, what you want to discuss about is what is the duration of an antibiotic. So we'll talk about that. So acute, for most purposes, what you will see is if you look at any ID component, if you have fever with UTI, irrespective of whether your CT or ultrasound shows or not shows, it is in the upper tract, as simple as that. If the patient is having chills, irrespective, aapne ultrasound bhaja, there is enough studies, it shows that actually there was one study in US which showed that if you look at symptom of fever and chill, it is more sensitive of showing that the infection has gone into the upper tract as compared to a USG radiological examination. Now, the other thing that you want to say is basically is the symptoms of burning, micturition, frequency, urgency. These are actually symptomatology of the lower tracts. Now, if you have a patient who is catheterized, then you are not going to see these symptoms. The only symptom that is helpful there is fever. The other thing that you want to see is what are the risk factors that they are present. You know pretty well there are certain risk factors which are always there. That is indwelling catheters, previous prior antibiotic usages, which actually determines what type of treatment are you going to plan for. And then there are behavioral things. People who are holding on certain jobs where they are holding on, infrequent voidings, frequent recent intercourses, that is something which can lead to frequent recurrent infections. And that physiological, of course, changes like pregnancy and all. And of course, there are certain genetic susceptibilities, and of course, the anatomical changes like you have stones or there is stricture and all, which I think we all must be knowing about. The symptoms and signs we have already discussed. Here, what I would go further ahead and talk about is that when you have a complication, you can have bacteremia, septicemic shock, perinephric abscess, renal failure, emphysematous pyelonephritis, different sorts which we can see. I'm pretty sure in the last 2 days, you must have discussed about all these complications and all. So we'll go basically to a diagnostic approach. As a clinician, the first thing that I want to know about in any UTI, urinary tract, is what is underlying condition. Is he having any other comorbid conditions or not? That's point one. And then when do you suspect? Suspicion could be, as I suggested, that it could be possibly because of just an increased frequency. It can happen in many elderly females where you may not even have the basic symptoms. The only thing it could be, it could be just that the patient even has an electrolyte imbalance of hyponatremia, which could be because of actually an UTI. Similarly, increased voiding, burning micturations, that has to be kept in mind. So once you have the symptoms, by and large, what you do is simple thing that you send a urinary sample. A sample for the routine microscopic examination and for culture sensitivity. What you find usually is you find cells, the normal cells, increased microscopic cells, and then you will also try to identify the organisms. One thing you should always try to see in the urine is leukocyte esterase activity. I don't know whether, I think now you get that in your SGPL code, that you should ask for a leukocyte esterase activity. Many times you might actually you might even see specifically in ICU setting, you will see that there will be 4 or 5 cells, and you might even see a Klebsiella which is still growing there. Now, more and more what is happening that you see is if your leukocyte esterase activity is not there, that means the WBCs which are sitting there, they're not actually actively fighting that organism. It is as simple as that. It is just a bystander which is sitting there. If you go on trying to clear it, what will happen is more and more colonization, and following with more and more resistance. And that is what is the basic cause of most of these ICU infections which become resistant. So you always try to see if you have cells, if the cells are very high, that's fair enough that you want to diagnose it. Otherwise, you have a borderline cell and you are growing some organism, look for leukocyte esterase activity, and that will determine whether it is actually a bystander or it is causing a pathological infection there. So choosing an antibiotic is something that we really wanted to discuss here. That is, what is the class of patient? what is the culprit, what is the bacteria, and the patterns of an institute. So coming to this, when you talk about the class of patient, the first thing that is as simple as ma'am was also discussing, that is whether you want the patient is from hospital setup or the patient is from the community setup. And then you also want to hear about what is the antibiotic usage greater than 65 years of age, hospitalized in last 5 years, last 5 days, and whether the patient was catheterized or not. So just let me ask one simple question. How do you take out the sample in a catheterized patient? How do you send a urinary sample? You were suspecting an infection. How do you send a urinary sample in a catheterized patient? I mean, that is something everybody is doing, right? Urologists, ICU guys, everybody, neurologists. Why you have to sample this? How do you send the sample? Pardon? Oh, so every time you want to send it to DNA, right? No. So how do you send it? That is the key point.
Wait for 2-3 minutes.
Okay.
And for me, the Folies will clean with betadine.
Okay.
Then with spirit. Then again with betadine and take the with 5 ml syringe.
5 ml. You
prick the Folies.
Prick the Folies where?
In between. Not in between. Means at the tip.
Somewhat correct. Correct. Actually, don't wait for 2-3 minutes. 2-3 minutes is suppose somebody has pretty good amount. Suppose normally a person will have somewhat 0.5 to 1 ml per kg per hour output. That is the usual, right? In 2-3 ml minutes, you're not going to get that much. You want first, you actually ensure that you just milk it a bit. Whatever is stagnant, you drain it out. Then you clamp it. Then actually after clamping, you leave it for at least half an hour. You expect some bit of urine to collect, fresh urine, and then you clean the hub of the Foley, and then you take a 5 ml syringe, insert, and then suck it out from there. Usually what people do is they open the Foley and then they start collecting. So then you will always get something or the other. The second question is, how many people are sending tip cultures, Foley tip cultures? Foley tip cultures, iska tip culture. How effective is it? That's what you're doing in the ward. But there are residents who are saying, yeah, I'm doing it.
Foley में टीचिंग पहले जाता था तब बंद करा दिया माइक्रोबायोलॉजी से लेना ही बंद
नहीं मैम टीवी से सेंटर लाइन so by and large the international guidelines is you say no tip culture, not even central line. The only place central line tip culture is actually allowed is one if you are saying all the people are not getting, or the patient is a febrile neutropenia. That is the only place where actually febrile neutropenia patient where you are supposed to send one, where you can actually allowed internationally to send for tip culture. Otherwise, no tip cultures actually are accepted anywhere. We are also emphasizing don't send tip cultures at all. That is second thing. Okay, so that is exactly what you want to know: where the patient is from, what type of thing, whether he's catheterized, whether he was catheterized, and what type of things that for how many you know that you say that the patient is an HAI after 48 hours. That is the usual definition, right? And then how long? कब तक आज मैंने डिस्चार्ज सपोज आज मैं डिस्चार्ज किया तो कब तक ये HAI है? 90 days for most organisms it is 90 days, but certain organisms it can be even more also. But for most organisms it is 3 months that you actually take into account. Okay. So the culprits that we know about are classically Escherichia coli. E. coli constitutes nearly 70% of all UTIs. And then we have Enterococcus group, which actually we know that is another thing which is becoming more and more common and is a very resistant organism. Then of course you have Proteus, Klebsiella, Pseudomonas, Staph epidermidis and all. Now, when you know this, the third thing that you want to know is that the third point which we discussed was this: the sensitivity pattern of your own institute. Do you have sensitivity pattern of your own institute? Because I'll tell you this very simple. What we have realized, but day by day, is that suppose we just think KGMC, right? It's an old institute with multiple buildings, looking old, depleted, some new ones. So I have IQ in one old building, one building. So when you collect data, what you see is the organism which is resistant. Suppose my trauma center organism, they come resistant. The IQs there, they show resistance to pan resistant for even Klebsiella. But same thing is when I look into my medicine department IQ, there the Klebsiella is actually still sensitive to amic acid. My IQ in Satabdi, where they have the oncological centers, there we are seeing that Klebsiella is not the most common organism. Most organism is Candida. So what does it show? It shows you cannot actually treat UTI by international guidelines hitting in India. Point one. You cannot treat UTI by guidelines which are being even brought out by ICMR or even by me, because your institute will have specific as per your antibiotic usage. And why is this difference? I'll give you one state, for example. In 2017, Department of Medicine, we have 14 bed ICU, out of which 8 patients used at a time used to be on colistin. Then we came up with this point that we said we'll count how many colistins we are using per month, per patient. We started doing that. And we said we wanted to see how many cultures actually are being reported, how many cultures, how frequent. Slowly it came down. Now the colistin in 2019, just before the COVID pandemic, the total usage of colistin in the whole year was 7. And I'm telling you, the patient profile same होता है, वो बदलता नहीं है. सब ये कहते हैं मेरा वहां से आता है, अरे मेरे पास भी सुबह से 4 मेदांता से ही आए हैं, कहीं और से नहीं आए हैं. So it doesn't change. It is how you actually create your own mileage. Now that determines, for example, if you are using more of minocycline, then your tetracycline group will be less. So second question, microbiologists must be there. There must be some urologists and all. आपके यहाँ पे UTI में as of now, which is the best drug that you see? They are not seeing their culture sensitivity, or they are not one of those things. So right now, though most of the guidelines suggest, international guidelines suggest this, if I was the first person, if my hospital specialty, as ma'am said, I would go with nitrofurantoin, because as of now, this is not international. Yes, nitrofurantoin is more sensitive, even better. Phosphomycin. Do you know how good phosphomycin is? Kitna अच्छा है? Anybody use phosphomycin? You must be using phosphomycin. Correct. 3 gram sachet, एक बार दो, एक sachet पूरा कमाल हो गया, right? The phosphomycin is so good. Now it has been said that even in pan-resistant antibacterial infections, you are getting IV phosphomycin because it has very good even visceral penetration. But that doesn't mean you start using left and right. But phosphomycin, as of now, its sensitivity is considered better than most other antibiotics. Okay, so phosphomycin, nitrofurantoin, and all are very good. Even Cotrim, that is your Ceftriaxone, has come back. It is showing pretty good sensitivity pan India. In many places, you are seeing very good sensitivity to cotrimazole. Cotrimoxazole. Cotrimazole fungal है. ठीक है. Now, question 2. You have a gram-negative bacteria. तुमको मिल गया. They say quinolone will not. Which quinolone will you use? अभी बात हो रहा है. Which quinolone will we use? Quinolone sensitive है. आपका लैब दिया quinolone sensitive 500 quinolone दे दिया. क्या quinolone यूज करते हैं? Gram negative bacteria है. तो आप क्या quinolone? Antibiotic selection ऐसी हो. What quinolone? Moxie should be avoided. Citro should be done. Anybody else? Not flog. What about levoflog? Why? तो 5 दिन हो गए. 8 दिन कितने दिन देने को? 3 हफ्ते. So 0.1, 0.2, 0.3. You're right in many ways. So Norflox, Ciplox. Ciplox is the drug of choice for most gram-negative. There is one thing. अगर आपको अपना pharma याद होगा, clonones have two generations. First generation, second generation. As the generation goes ahead, the gram positivity action goes on increasing and gram negative action decreases. The first generation has a stronger gram negative action. So your UTIs are basically gram negative organisms mostly. So your first choice is always quinolone or specifically cryptococcus. And specifically male. Why in male do you use quinolone? Right. It has very good penetration into the prostate. So exactly like your ceftriaxone also. They have very good penetration into the prostate. So that is why you select quinolones. And quinolones usually is cryptococcus is a drug of choice. If you look at all international guidelines, wherever they want to hit pseudomonas, it is always cryptococcus when they use quinolone. The more you go further down, moxi is actually more of a gram positive as compared to a gram negative bacteria, antibiotic. Okay. Suppose if you have an enterococcus, then what do you use? But UTI में यही है, E. coli, enterococcus, Klebsiella, you are done and then you have. So what do you use for enterococcus? Pardon? I didn't get it. What is it? Ampicillin sulbactam. Yeah, you get it infrequently here. Anything else? Okay. Point 1, 2, 3, 4. Vancomycin, cryptocurrency, linezolate, apomycin should be used only if you are found. If you look at the CLSI, if there is any microbiologist resident here, he or she will say, then as per the guidelines, they won't put linezolate if you are anything before that is sensitive. That is point 1. Dapto is not a great drug for actually using it for urinary tract and all those things. It's not a very good drug as such. But you have to remember another thing. Your labs will give you something like a meropenem sensitivity and all. So, but you have to remember that enterococcus activity, in vivo action of meropenem against enterococcus is very poor. So the drug of choice goes like this. The first generation penicillin, the third generation penicillin, and if the third generation penicillins are not acting, then you go for Vanco or Tico or Linate. Or now if you're using, sometimes they give you aminoglycoside. If you're using aminoglycoside, it has to be high dose aminoglycoside along with secondary another drug if it is sensitive. You might use another quinolone. That is what you have to remember. So, अगर आपके lab में meropenem लिख के आया, don't start using meropenem for an enterococcus. It doesn't actually make much difference. It doesn't work very well there. So, your antibiotic profile, which you are selecting, has to be seen in toto. Its penetration into that organ. Its actual final thing is how does it act in vivo. So finally, how long do you give? What is the final dosage? How long do you give? Duration kitna dete ho? So what we have written is 5 to 7 days, right? So now here you actually have to identify the site of infection. Bladder tak hai, urethral bladder tak hai, it is actually only 3 to 5 days. It is only in severe sepsis or nephritis that you have to use for 2 weeks, maybe even sometime for 3 weeks. But for all other infections of UTI, 5 to 7 days for most purposes is good enough. If the patient is critical, then you can use for 10 days. And then after stopping your antibiotics, give a 5 days clearance period and repeat your urinary sample. And then you might, if the patient has got complete clearance, that means you have completely cleared the infection. Otherwise, if there's incomplete clearance, then you will see again start a rise in your cells. That is how you try to actually treat, specifically if the patient had fever episodes before you started antibiotics. So this is something basic that we all know about. For short course, lower, you need 3 days treatment, a Ciplox or a nitropentane good enough. And for reinfection, for what you want to prevent, reinfection is basically you say when ये आपने किया, आपने stop किया, उसके 5 दिन बाद आपने किया, clear हो गया, उसके बाद फिर हुआ, and एक साल में more than 3 times हो रहा है, that means the patient is having recurrent complicated infection. In such patients, you need to put them on prophylaxis, and the prophylaxis is usually nitrofurantoin. Candida, of course, you all know about it. Best thing is you remove the catheters and all, and you need at least 2 samples before you say that it is candiduria. And of course, and you can use fluconazole. But if you have very severe sepsis, then you can use echinocandins. So that's a little bit about all this. Thank you.